Hey folks, we're back here for item number 17 or tip number 17 in our medical exercise training 101 ebook video series. Now this is one that we find has grown in frequency since COVID, one, but also over the course of probably the last 10 years. Now we started this 28 years ago, but over the last 10 years we're seeing more and more. And this question is, at what point should I begin working with the client after surgery? Now folks, when I came out of PT school, there was no discussion of the fitness professional or a medical exercise professional working with a client after surgery, any point before, say, 3 to 4 months. After that 3 to 4 month mark, yes. But anytime before that or prior to that was just unheard of. But because of the cutbacks we're seeing in health insurance reimbursement, now things are changing drastically, which means for you, this becomes a challenge as a medical exercise professional because you could potentially bite off a client or bite off a situation with a client that's more than you can deal with. So let's talk about this one a little bit. So number 16, at what point should I begin working with the client after surgery? Before you begin working with a post-surgical client, you must have clearance from the operating physician, not the general practitioner, the operating physician, the man or woman, lady or gentleman that actually did that surgery, because they know what they found when they got in there. They know what the healing constraints are. They know when it was done. They know all the complications. You need that clearance from them. In most instances, you can get clearance from the client's family physician or physical therapist, but it may be more difficult to obtain clearance from the surgeon. The surgeon has intimate knowledge of the procedures performed. He or she must give medical clearance. Usually the optimal time after surgery to begin MET anywhere is about anywhere from 4 to 12 weeks. This may vary depending on the surgery and the client's recovery. Usually physical therapy is indicated and prescribed after surgery. The physical therapist has the equipment and the skills to reduce the client's swelling as well as managing their pain. Due to insurance limitations, the client may be discharged from physical therapy before their restoration of optimal function. This is when medical exercise training is indicated. For arthroscopic procedures, usually the waiting time for MET is anywhere from 2 to 4 weeks. That may be longer. For the more involved surgeries, such as ligament or tendon reconstructions, usually 6 or 8 weeks. For total joint replacements, it may range up to 4 to 8 weeks. For back surgeries, 8 weeks plus. These times may vary depending on the client's health, the intricacy of the surgery, and the healing time required. But please always understand, there should be some intervention of physical therapy in this post-surgical scenario. We shouldn't jump directly to medical exercise training. I know some people may take offense to that, but you don't have the modalities to control the inflammation. You may not have the ability to go in and clean the wound after surgery, or maybe the surgical bandage falls off. I know in our physical therapy offices, we had all those capabilities. So sometimes that client immediately after surgery may not be the best client for you. And let me continue on. In our medical exercise training protocols, we all outline MET criteria for some 60 medical conditions. As a medical exercise specialist, you will assess the client to determine if they meet the criteria to begin exercise. If they do not meet the criteria, refer the client back to their physician, therapist, or chiropractor to make program modifications. The MET criteria is established to ensure an inappropriate client doesn't enter an exercise program. Adhere to the criteria to avoid exacerbating the client's condition. Now, I know some of you may ignore that criteria, and we were very specific with regard to swelling, their pain levels, their activity levels, even timetables, 6, 12, 8 weeks after surgery. And we put those together because of what we'd seen in clinical settings in our 8 offices where we did a lot of post-operative care. We did knees and shoulders and backs and hips. We did everything. So this is based on our clinical experience, but also that clinical experience was based on what the standards were in healing and also in surgical management. Now, we're not saying that you should take the place of the physician, the therapist, or the chiropractor, make these determinations. We are saying we realize healthcare has changed, and there will be some instances where you work with clients after surgery, but that first person to manage that client in any type of exercise or rehab setting, I'm going to vote 99.9% of the time should be the physical therapist and or the occupational therapist. So please be mindful of that. Medical exercise training works great for post-surgical clients. Just make sure the client is medically stable to begin the program and you have the necessary clearances. One of those clearances should be from the operating physician. Not just their family doctor, but the operating physician. And we had a situation not too long ago with one of our MESs that had started working with a client. This gentleman was probably in his early 30s, but he had undergone a surgery when he was in his teens, and that surgery done in his teens required a follow-up surgery be done somewhere within 3 or 4 years of that initial surgery. Well, this young man hadn't done the follow-up surgery, so now he's in his 30s. He's out participating in recreational sports, and he's having significant pain and discomfort. And in that scenario, our MES took the client on without ever seeking to speak with the client's, the physician that did the surgery before, which was many, many years ago, but also even checking with the client to see if he could communicate with a current physician that was monitoring the service or monitoring the client's condition, which means there's a huge gap there. And with that huge gap, that now says there's a potential here for a major problem. So just because you get clearance doesn't mean that you can proceed, but then also just because the family doctor says, hey, you can work with the client, doesn't always mean the family doctor understands all the ins and outs and do's and don'ts as to what went on with this surgery. In that particular situation, we eventually got our student to refer the client on to another orthopedic surgeon, who then in consultation determined that the client did need the second surgery done. For some reason it wasn't done, and that client went on to have that second surgery. So please, if you would, the client after surgery, this is a very, very sensitive situation. I know the idea of working with an ACL or total hip replacement after surgery is great, but let me ask you this. If your mom or dad or aunt or uncle was in Phoenix or Albuquerque or Madison, Wisconsin, and they called you and said, well, the doctor says I don't need physical therapy, I'm going to work with a personal trainer, would you have a little bit of concern? And that leads me to the next question. Do you know everything that needs to be done with that client post-surgically with that hip replacement or that ACL reconstruction, that kind of thing? And will you make sure that they don't get an infection or develop an infection or something along those lines? So not trying to be morbid here, but just trying to make you think. We have to start thinking more professionally and more ethically as to what's in the best interest of the client, not necessarily what's in our best interest to take the client on. So with that one, we'll see you in our next session. Our next session is going to talk a little bit about insurance billing. Please make sure you come back and join us for that one. Take care.